I'm starting, right? Can you hear me? Noman. Okay. Assalamu alaikum. Good morning, students. How are you? Hope you are doing well. And today we are starting our lecture. I'm Dr. Muneera, your facilitator coordinator for today's lecture. The topic of my lecture is on trauma. Let's start the lecture by setting up certain ground rules to avoid any turbulence throughout our 1 hour of interaction. You can park your questions on the chat box in case. I will answer your questions at the end of a lecture one by one by the name of the student who has sent questions. In case I ask you guys questions, then I will give you 30 seconds to answer it by typing up on the chat box, right? So let's start the lecture by judging your past knowledge of trauma. So my first question to you guys is, enlist different causes of the trauma you know. Please write your answers in the chat boxes. And sorry guys to have a late start because of some technical issues from the IT department. Hope afterwards our journey will be smooth. Okay. We have a list of answers. Then mechanical, road traffic, firearm injuries, yes. So we have 2 answers up till now. Different causes means we at least have more than 3 causes to be minimum, right? But you guys are right. Okay. So there is a sports injuries, right? Road traffic accidents, history of fall from the working place, that there must be a stab injury, gunshot injuries, right? Now let's start by discussing a scenario. 25 years old male rider of motorbike had road traffic accident with a car coming from one way breaking the traffic rules and had fall striking the footpath corner. He's otherwise alert but in pain and agony. He was taken to the emergency department. His vitals indicates heart rate of 110 beats per minute, blood pressure of 110 by 70 millimeter mercury. Abdominal examination revealed bruise at the left hypochondrium with the positive Kehr sign, and his fast was positive. How will you approach him now? Right? How will you approach him now? Write up your answers in the chat box, and please do not reveal on the chat box till I say. Right? Park your questions to your side, but do not reveal on the screen. We will reveal at the end of the lectures the answers of all the students at once, right? That this should be the one limitation to that, okay? So now question 2 is 35 years old male victim of street crime in an incident of a mobile snatching sustained stab wound by a hooligan at Saturday night. He was taken to the emergency department immediately by locals. During the examination by the emergency physician, he was found to have following. Can you see the picture? And what do you find out, what you can see on a picture is basically is a finding of this injury. Now, how will you proceed in this case? So case 1, case 2. Guys, now you can reveal your answers on the chat boxes. Okay. Now, question 1 and question 2. So you have to answer answer 1 and answer 2. So I supposed to understand what is your approach in answer 1, what is your approach in 2. Okay. Bullet insight. Okay. So, and in case 2, we will disinfect the area and stop the bleeding from the lower penny wound. Okay. But in question 2, Shamil, it was the stab wound, not the bullet wound, if I'm not wrong. Yeah, dear. It was a stab wound, not the bullet wound. Any other right answers? Once you have done the guys, and then we'll discuss the answers at the end of this lecture. Let's see how many of you have picked the right one. So no more answers. No more answers, then we can proceed with our lecture. Ultrasound. Okay. So with this background, let's start our lecture on approach to abdominal trauma. Trauma आ रही स्क्रीन? आवाज तो आ गया जी मैम, स्टार्ट करें. अच्छा ठीक है. Assalamu alaikum students. Sorry for interruptions. It was again an IT issue. That's why we could not able to deliver further. Okay. Now let's start. We were on the ATLS. So what is ATLS? I want you to answer this question, guys. What is ATLS? Yes. Chat ma'am, and please give a functional contact number. Advanced trauma life support. Okay, good. Shamil was the first person who has answered. ATLS means is advanced trauma life support. So the advanced trauma life support program was developed to teach doctors one safe, reliable method to assess and initially manage the trauma patients. The ATLS principles represents an organized approach for evaluation management of seriously injured patients and offers a foundation of common knowledge for all the members of the trauma team. Right? What is a quick way to assess the patient in 10 seconds? Students, please write down in your chat boxes. What is a quick way to assess patient in 10 seconds? Can you hear me, students? It is A, B, C, D, E, right? This is a 10-second formula. So you will go for the primary survey, which is A, B, C, D, E, along with immediate resuscitation. This is the one way to assess the patient in 10 seconds. So what is, in other words, what is ABCDE? Airway maintenance, A stands for the airway maintenance with the cervical spine stabilization or protection. B stands for breathing and ventilation. C stands for circulation with hemorrhage control. D stands for disability along with assessing the neurological status. E stands for exposure along with environmental control, in which you have to completely undress the patient but prevent hypothermia at the same time. Right? Right, guys? So what are the other components of this methodology? ATLS has this is methodology of assessing the trauma patients, we know, but the one component is the primary survey is ABCDE, but there are other components which are incorporated into this system. I want you guys to answer these questions. I don't want any bright. I do not want exact bookish answers, but anything that comes up in your mind, what could be the another component can be incorporated with this methodology along with the ABCDE. Please write in your chat boxes. Osama Rafiq. Please read the slides a bit slower. Okay. Osama, you wanted to say a bit slower means what in terms of pace? Okay. What are the other components of this methodology? Okay. Okay. I will be a bit slow. Did you get my question, students? What are the other components of this methodology besides A, B, C, D, E? Okay, no answers. This methodology includes primary survey, but before that, we have preparation and triage. This is the part we're supposed to done in the field when the trauma occurs. Okay, so it's a pre-hospital component, the preparation and triage. The third component, primary survey, occurs within the hospital setting because in the scenario, your patient was presented to the hospital. That's why the upper two components doesn't incorporate into that. We'll start directly from the primary survey. After primary survey, we go for the adjuncts to the primary survey and continue it with the resuscitation. We'll discuss what are these adjuncts. Then after that, if there is a requirement or a need to patient transfer to the higher centers, we need to decide this moment whether you have that facilities or not. Then comes secondary survey, in which you have to examine the patient from head to toe after taking an ample history, in which you have to quickly have to take up the history of a patient according to the history of the trauma, what was the event that has been taken place, past medical history, the personal history, and the consequences that have been followed by this trauma. After that comes adjuncts to the secondary survey, continued post-resuscitation monitoring and evaluation, and last but not the least will be the definite care that is provided to the patients, right? So the adjuncts to the primary survey are ECG, pulse oximetry, capnography, the arterial blood gases, urinary and gastric catheters, X-ray examination, which includes chest X-ray, pelvis X-rays, and diagnostic studies, which include FAST, EFAST, and DPL. Right? Now, what is the common cause of shock in trauma patients? Again, a question for the students. Write down your answers in the chat boxes so I can see. Hemorrhage is a common cause of shock in trauma patients. Right? So coming to now the abdominal trauma. This abdominal trauma can be either blunt or penetrating. And on top of that, we can say further classify whether it's a stable trauma or the unstable trauma. Stable and unstable stability will determine on the basis of hemodynamics. Hemodynamic means what is the pulse of a patient, what is the blood pressure of a patient, what is the oxygen saturation of a patient, what is the consciousness of a level of a patient's, and what is the respiratory rate of a patient's, right? This tells you the stability and stability. If these vitals are within the normal range, then the patient is stable. And if these vitals are not in that normal ranges, then we call it unstable patients, right? Now, coming to the blunt abdominal trauma. The blunt abdominal trauma is very common, and the prevalence of intra-abdominal injury following it has been reported as high as 12 to 15%. The mechanism resulting in the blunt abdominal trauma were motor vehicle collisions, which accounts for 73%, followed by motorcycle collisions, which are 7%. Then comes the auto pedestrian collision, with 6%, and history of fall that accounts for 6%. The blunt abdominal trauma accounts for 15% of all major trauma cases. Of these, around 30% will require laparotomy and 80% will require angioembolization. Diagnosis of blood abdominal trauma remains a challenge to the surgeons, as injuries commonly occurs in patients with multi-system injuries and no obvious external signs of trauma is revealed as such. Coming to pathophysiology of blunt abdominal trauma. Rupture or a burst injury of a hollow organ by a sudden rise in the intra-abdominal pressures, crushing effect, acceleration and deceleration forces leading to the shear injury, especially at the level of a blood vessels or mesentery of the abdomen. Seat belt injuries, which highly correlate with the intraperitoneal injuries. This pie charts will tell you the common organs involved in terms of the frequency of prevalence by the blood abdominal trauma. The commonest organ is the spleen, which has been injured in the blood abdominal trauma, followed by liver, then comes the kidneys, and last but not the least is intestinal injuries. Now, how will you start suspecting there's something is going wrong with the abdomen, despite of no wound on the abdomen? So you start suspecting when you see patient has a history of a trauma, because history is very important. That's why we have written in a secondary survey, you have to take a very good history, though it's short, but a history. What is the mechanism? Mechanism will clearly define you what was the reason behind this injury. So if your patient is present history followed by the presentation, number one is vitals, and second, and the third, on a third number, it will be on examination of the body parts which are involved by the trauma. So mostly your torso is involved by the trauma in general surgery, and being a general surgeon, we are supposed to see the torso. We're not supposed to see the peripheries, because this is comes in the domain of a orthopedics. You don't want to see the head injuries because it comes in the domain of a neurosurgeon. So what you see is the torso part or abdomen part. So in the abdominal part, if you start looking up that abdomen is distended, then you start suspecting, is it pneumoperitoneum or is the ileus? Then you see if there is any bruise or not, because since it's a blunt trauma, so the continuity of skin has not been breached. What you see, it could be small abrasions or it could be the bruise. When there is a bruise or ecchymosis of the flank, we call it a Gray Turner sign. When there is a bruise around the umbilicus, we call it a Cullen sign, and both are the indicators of retroperitoneal hemorrhage. Abdominal contusions in the form of left belt sign. We might have a decreased bowel sounds. On a digital rectal examination, there is a blood or examining finger. On a urogenital region, there must be a blood or urethral meatus or bruising of external genitalia indicating pelvic trauma. This is how you can see the seat belt sign. Bruise in the flank, which is known as Gray Turner sign. Bruise around the umbilicus, we call it Cullen sign. Both are the indicator of intraperitoneal hemorrhage. This is known as Keher sign, which was present in our first scenario. There's a patient will felt pain in the left shoulder tip after the blunt abdominal trauma, and this is an indicator of a rupture spleen. It's known as positive Keher sign. Now coming to the adjuncts investigations, which we have discussed. So in adjunct, make sure every trauma patient, when they come up to the emergency department, you have to maintain his large bore IV cannula in the upper limb, mostly the antecubital fossa, and that the cannula, the size of cannula should be 14 to 18 gauge, not above that, because we need a good volume bore to have a good resuscitation. Followed by, you need to draw the sample for the cross match, for the baseline hematology and biochemistry, arrange blood products. You go for the baseline chest X-ray, which is an adjunct of a primary survey, to rule out the injuries, especially the hollow vessel injury. Then going to the FAST, which is focus assessment sonography in trauma patient. Now, the focused abdominal sonography for trauma is the evaluation of a torso of a patient for free fluid suggesting injury to the peritoneal, pericardial, and pleural cavities, particularly in trauma. It is non-invasive, rapid, and is a bedside investigation. It's safe in pregnancy and in children and can be repeated serially and mostly present in every institute. This is the abdomen. This is the foresight supposed to take it. The xiphoid process in which you put the probe of the ultrasound and you check for the pericardial fluid collection. Right now, this is one space, and then another space is right hypochondria, right upper quadrant, where you look for the right pleural, subphrenic, hepatorenal, and inferior pole. Left-sided, same approach, but just the addition of a splenorenal component instead of a hepatorenal component. And last but not the least is suprapubic, where you see the retrovesical recess and pouch of Douglas for the collection. This is how you see it. If you have a fluid collection, the fluid will appear in black color. And this your organ is spleen, which have a gray attenuations there. So this is a free fluid around the spleen, okay, which is most probably will be the blood around the spleen. This is a bladder and this is a fluid. So these are retrovesical fluid. Then comes the DPL, which is diagnostic peritoneal lavage. In this DPL, mostly when you have equivocal signs and you're suspecting the intra-abdominal injuries, and which is not evident on the FAST, which is not evident on the X-ray chest, which is not been clear on your physical serial abdominal examination, then you're supposed to go for the one step ahead. That is the invasive approach. And this invasive approach is diagnostic peritoneal lavage, which we normally call it as a DPL, in which you have to put a small incision or cut below the umbilicus. Okay, you will breach the fascia, and then you will put the catheter inside that and inject the normal saline and then aspirate. If you find a frank blood inside that, that would indicate hemorrhage. If you aspirate a yellow color fluid, then it indicates small bowel perforation. So this is the some indications of the diagnostic peritoneal lavage. Number one is the equivocal abdominal signs. That means your abdominal signs do not correlate with your investigations. Unexplained shock, altered sensorium, that the patient might be under the influence of alcohol, drugs, head injury, or he's unconscious. That's why he cannot able to give good history to you, and maybe he's not responding in that way which you want to be. Unavailability of the CT scanners in the area or where you are working, like small hospital, you can say Tehsil hospitals or DHU hospitals, district headquarters hospitals, not a tertiary care units, right? Normally, DPL has been replaced by CT scanners in the setting of a city or CT scanners, right? In tertiary care unit, we don't do the DPL as we have a CT scanners are available. How do you interpret this? Receiving of 10 ml of a frank blood is the positive DPL. Or if you put this, any fluid, aspirate under the microscope and see the RBC count of more than 100,000 and WBC counts of more than 500,000, then that is positive for the positive DPL. If your biochemistry indicates the amylase level of more than 175 millimeter, and your microscopic investigation reveal food, fiber, bile, and bacteria, we call it as the positive DPL, right? Okay. Now comes the CT scanner. Second is the CT scanners, which is also the part of adjuncts, but the secondary adjuncts, not the primary adjuncts, in which you can able to find, like in this CT scanner, you can see that on the left side, the arrowhead indicates the spleen has injured. And this is a blood around the spleen, indicating splenic trauma. To whom you would like to go for a CT scan abdomen? Yes, this is a very important question. excuse me, to which category of patients you would like to go for a CT scan abdomen? You can write your answers in the chat boxes, students. Okay. Hemorrhage blood. On which category of patient you would like to go for a CT scan? With bruise on abdomen? Okay. Non-pregnant females? But Sakina, my question is that every non-pregnant female will has to undergo for the CT scan, irrespective of the mechanism of injury. Even a small slip in a bathroom, you will ended up doing a CT scan of abdomen in this category. Okay, so the predictor of a post blunt abdominal trauma patients requiring CT scans are hemodynamic stability, defined as systolic blood pressure of less than 90 millimeter of mercury. They cannot below that. When patients is suddenly dropping the blood pressure, though first he was maintaining it, and then suddenly he started dropping the blood pressure while you were doing the resuscitation. Evidence of head injury, low or fluctuating GCS, that is evidence of head striking, including the loss of a consciousness, intracranial hemorrhage, skull fractures, CSF leak, or neurological symptoms. Severe injuries to the pelvis, chest, or extremities, including severe pelvic rib and limb injuries, that is the polytrauma patients, and low hemoglobin level, less than 30% is indicator, right? So number one, when the polytrauma patient is involved, you have a low HB. While resuscitation, patients start dropping the blood pressure when you have concomitant head injuries and patient is unconscious or drowsy. Then you would like to go for the CT scans in a blood abdominal trauma category patients. This is a slight comparison between the different modalities of DPL, FAST, and CT scanners. DPL is diagnostic peritoneal lavage. FAST is the focused abdominal sonography for trauma, and CT scanner, of course. So what characteristic has to be documented on DPL? Whether the patient has bleeding or not. In a FAST, is there is a free fluid or not. And CT scan have a 1 point ahead, will also give you the detailings about the organ injury, whether the liver is injured or your spleen is injured, right? Okay. So blood pressure status with reference, mostly we'll go low blood pressure, we go for the DPL, and low blood pressure, we go for the FAST, but CT scan, we always go for the normal blood pressure, unless initially, but in between, we start dropping. Constant low blood pressure is not the indicator to shift to the patient to the CT scanners. Remember that. As per the sensitivity, DPL has a sensitivity of 98%, FAST around 80 to 97 because it's operator dependent, and CT scanner is at 98% sensitivity. Specificity wise, it has a low, FAST has got moderate, and CT scan has got a very high specificity. What are the injuries you might miss on DPL? Diaphragm and retroperitoneum. FAST may again bowel, diaphragm, and pancreas. On CT scanners, normally you again miss diaphragm, bowel, and pancreas. Disadvantages: DPL definitely is invasive one. FAST is operator dependent, and CT scanners, number one is the availability, tertiary care unit, expenses, that's cost, and is definitely will be time consuming. The unstable patient could not sustain the prolonged time to get CT scan done. Now coming up the treatment options for the blood abdominal trauma. Number one is the conservative along with blood transfusion. Initially, if you cannot find anything wrong in this category, like no visceral injuries there, if there's visceral solid organ visceral injuries there, which is indicated on FAST or CT scan, or on X-ray, you will present it with the free fluid. So you will go for the conservative trial by giving the patient IV fluids, blood, analgesia, antibiotics, observation, and serial abdominal examination. Option 2, when your patient has some organs in organic injury is present, like spleen is injured, liver is injured, or small bowel is injured, then you really have to go for the invasive procedures like surgery. And a surgery in a trauma is known as laparotomy, and this laparotomy is damage control laparotomy. Third option in the nowadays is angioembolization, but this option is reserved to be present only in tertiary care units or where the expertise of VIR is available, because angioembolization cannot be done by every institute frequently. This can only be done by the trained radiologists who can do this invasive procedures, angioembolization, which is the intervention radiology procedure in which you block the arteries by glue or by sponge which are bleeding in particular area to arrest bleeding. Right? Now coming up, the predictors of laparotomy. When you suspect and say this patient requires surgery, like we have discussed, which patient requires CT scanners. We have said which patient requires a particular investigation. Now, which patient require laparotomy? Hemodynamic stability, constant low blood pressure. Is not, you don't have a recordable blood pressure, patient is dropping the hemoglobin, he is pale, he's cold, clammy skin, that means patient is bleeding inside very badly, and you need to open up to control the bleeding until you will lose your patients. So you have to be prompt in this condition. You do not wait for the labs, just like you do in a normal scenarios. In a trauma, the situation is different. First, you fix the issue, and then you look for it. Okay, you don't wait to see what will be going on. We will wait for the labs. No, you will lose the patients. You have to act very promptly. That's why we have a rule of 10 seconds to decide whether this patient will go to the OT or will go to the ward for the conservative management. Or any patient having the evidence of peritonitis to achieve control of hemorrhage and control of spillage from the bowel are the candidates for the laparotomy. Traumatic diaphragmatic injury with herniation of a contained into thoracic cavity, leading to shortness of breath. Severe solid organ injury like kidney and spleen, which are completely shattered. Infarction due to post-traumatic occlusion of a blood supply to the gut. Mesenteric tears, which they bleed like a hell, and you need to control bleeding. Unexplained moderate to large amounts of free fluid, that is more than 500 ml, and there's a failed non-operative management that you given the trial to the patient for 24 hours and see the vitals are not getting normalized and hemoglobin is not maintaining despite of transfusions, then you take these patients to the OT for explorations. So these are the indicators for the laparotomy in cases of a trauma patient, which is blunt abdominal trauma patients, remember. Angioembolization has revolutionized the non-operative management of the blunt abdominal trauma in all hemodynamically stable patients with the evidence of extravasation of a dye on a CT scan. Modern clinical practice guidelines recommend the use of angiography with embolization possible. Do not explore, right? But despite all, we have certain pitfalls in the blunt abdominal trauma or a BAT. What are these pitfalls, guys, if you can say? But we have investigated the patients, we have revolutionized the treatment by going for the fancy stuff, but still we cannot able to answer certain questions. So what injuries you can miss initially in a blunt abdominal trauma that needs high index of suspicion? Answers, if type in your chat boxes, guys. What injuries you can initially miss in blunt abdominal trauma patient that needs high index of suspicion by a trauma surgeon as per the mechanism of injury and clinical examination. Intracerebral hemorrhage, Hadika, Okay, you can miss intracerebral hemorrhage. Now, because we're talking only abdominal trauma, so we would like to focus on the abdominal part, torso part, not the brain part. Your intracranial hemorrhage part will be dealt in your head trauma, not in this. Remember, we are going for the abdominal trauma only today. So I would like to have answers based on that area and locations there. What are the injuries you might miss in BAT, in which you require a high index of suspicion? We're talking about within the abdomen, right? Okay. अच्छा मैं देख लेती हूँ, कर लेती हूँ. हो गया? हो गया? Screen?
जी.
हो गया, okay. Rupture viscera. Okay, Shamil Khan is rupture viscera. Rupture viscera is what? Remember, the rupture viscera means what? Hollow organ and solid organ. Solid organ, you can get it from the ultrasound and CT scan, and hollow organ, the solid organ. And hollow organ means a breach in the intestine or a stomach, so in which you get the free gas under the right hemidiaphragm. So you'll get the pneumoperitoneum on a chest X-ray. So you can't miss this on BAT on routine investigations. What are the injuries that you miss in BAT? Renal vessel injuries, Zenona, very easily picked on CT scan. Very easily. They are very easily. Hardly missed. Anything else? If no, okay. Any other bright answers? Okay. These are pancreatic and diaphragmatic injuries. So these are the two injuries or injury pattern that are basically missed in a blunt abdominal trauma initially. So pancreatic injuries include transaction, contusions, or lacerations. These injuries may not be apparent on initial CT scanning. A repeat CT scan after 3 or a day 4 or 5 after trauma, or maybe on a day 2 or 3, is indicative of its injury level. Initially, you might get the normal CT scans. If higher index of suspicion categories, you might need to repeat the CT scanners on a day 3 or 4 of a trauma. Increased morbidity, mortality, if reported, the abdominal trauma and pancreatic trauma, if there is involvement of pancreatic duct due to complication including infected pseudocyst, abscess, fistula, or sepsis. Cardiac injury, pancreatic injury. Okay, good. So this is a CT scan in which you can see that these two arrowheads indicating the transection at the head of the pancreas, which also involves the duct of pancreas. This is also CT scan. This is pancreatic duct, and this is the injury at the level of the neck of pancreas. Diaphragmatic injury. While the diagnostic accuracy of CT scan for detecting diaphragmatic trauma has traditionally been considered low, the CT finding includes direct visualization of diaphragmatic discontinuity, herniation of abdominal viscera into the thorax, and the collar sign, a vest-like constriction of herniated abdominal contents through the diaphragmatic rent, are the indicators of diaphragmatic injury. Diaphragmatic injuries are generally managed operatively because there are no conservative management of the diaphragmatic tears. Small tears can still be missed in diaphragmatic injuries. Only big tears leads to the herniation contains in the thoracic area, right? This is the CT scan, and this is a chest X-ray. In a chest X-ray, you can see the stomach is herniated to the thoracic cavity. This is a CT scan of the same patient, and you can see the stomach. This is a rent. This is a normal diaphragm continuity in the right side, but on the left side, there's a rent, a big rent. So the stomach and small bowel part is herniated into the left thoracic cavity. Okay. What other studies you would like to do in order to evaluate the patient besides these studies here? Right? You have done ultrasound, you've done DPL, you've done CT scanners, but still, before in blunt trauma patients, there are still another investigation supposed to ask to answer your further questions. What are that investigations you can do? Remember, you're not rushing to the surgery right now, but you have plenty of other options you can apply. in order to diagnose the disease? What are that other studies you would like to order to evaluate the patients? PT, what are this? Cardiac injury, PT, and APTT. Okay. Coagulation profile is the routine part of your blood investigations, which you do in asking for the blood samples and all that. This is not selective one. Maybe anything else, students? Examination peritoneal fluid, but examination peritoneal fluid means that you're talking about the DPL. We have done the DPL, dear. We are going for another options. Can brain injury be detected by the pancreatic enzymes? Yes, it can be. But you need a high index of suspicion that you are suspecting this injury. That is very important. In a polytrauma patient is complaining of pain at every part of the body. So you cannot pinpoint pointly, you can able to identify these causes because pancreatic enzymes are not the routine enzymes done for a trauma patients until indicated specifically. Okay, no worries there. So these are urethrography, in which you able to detect any urethral injuries; cystography, in which you able to indicate or deal with the bladder injuries; intravenous pyelogram; gastrointestinal studies, just like barium meal or barium swallow, okay, to indicate esophageal injuries, right? So this is what it's supposed to do, right? Coming to the penetrating abdominal trauma. Penetrating trauma occurs when a foreign body object pierces the skin and enters the body, creating a wound. In penetrating trauma, the object remains in the tissue or passes through the tissues and exits the body. An injury in which an object enters the body and passes through is called a perforating injury. Perforating trauma is associated with an entrance wound as well as the exit wound. The most common cause is a stab or a gunshot. The most common organs injured are the small bowel, large bowel, liver, and intra-abdominal vasculature. Unlike the organs involved in blunt abdominal trauma, in which the spleen was first, followed by liver, right? And then it was the kidneys, and then it was a small bowel. Over here, it was a small bowel first, then comes a large bowel, then comes a liver, and then comes into abdominal vasculature. Suicide and homicide are constantly high causes of death in cases of penetrating trauma. Approximately 40% homicides, 16% suicides by firearm involved injuries to the torsos. What are the indications of laparotomy in cases of penetrating trauma? Just like the predictors of laparotomy cases of blunt abdominal trauma, there are also the indications of the laparotomy cases of penetrating trauma. So what is your understanding about that? You can again write in the chat boxes, students. No answers? Okay, 2 answers. Let me see what they have wrote. Internal bleeding and paleness. That means the patient is okay. One was this hemodynamic stability. Okay, Afreen. No exit wound. Okay. Okay, let's see what is the answer on the slides. Hemodynamic stability, it was correct. peritoneal signs that patient have a signs of peritonitis. There's intraperitoneal free air, which is indicated as a pneumoperitoneum on chest X-ray rect. Evisceration, that herniation of a portion of a bowel into the wound, which is be entrapped. Last में था gastrointestinal hemorrhage, the internal bleeding. So that was the true indicators of the laparotomy you need to do, right? Diaphragmatic injury, gunshot wounds with peritoneal breach. So this is the X-ray chest in which there is a free air right under the right hemidiaphragm. This is known as pneumoperitoneum. This is indication for the laparotomy. This is not evisceration in which there is a stab wound and a large bowel is coming out from the wound into the exterior. This is known as evisceration of a bowel loop. This is definite indication of a laparotomy. So now coming to strategically planning this categories of abdominal trauma patients. So when you have a blunt abdominal trauma patient, you have two choices. Either your patient is hemodynamically stable or unstable. If he is hemodynamically stable, then you have a plenty of time to work on it. Like you can go for the serial abdominal examination, or you can go for the CT scanners. Like we work in tertiary care units and we're working in the city. So mostly every hospital has the available with this scanners. So in CT, if you find out intra-abdominal injury, then you go for the laparotomy. Now, intra-abdominal injury in which sense? Either in the form of bleeding, solid organ injury, in the form of in the form of pneumoperitoneum, small bowel, then you go for again laparotomy, and or there is a bleeding, then you go for the embolization option. And if there is nothing, then you need to observe the patient serially. In or if you find no abdominal injuries, so again you can just keep sight by patient and observe for 24 hours how he is doing, right? In cases of embolization, you might have a failed attempt, then you can go for the second step, which is laparotomy. In observation, ma'am, if you find the patient is not getting better hemodynamically, then you will go for the laparotomy again, right? Still you haven't found anything on a CT scan, no problem. If patient is not getting better, go for the laparotomy. In hemodynamically compromised patient, that means not maintaining the blood pressure, not maintaining the heart rate, he's dropping his hemoglobin, okay? And then you will definitely go for the fast at the bedside. If turn out to be have a free fluid, you go for laparotomy. But there's no free fluid, then you have to look for the other signs or causes of hypoperfusion. What are the other cases which can lead to this condition? You have to go for the concomitant head injury. You have to go for the periphery. Is there is any femur fracture, pelvic fractures? Okay, it is lead to the large bones also bleed very badly, right? Or may you can go for the even DPL in this category, right? If patient is not stable. Coming to the penetrating wounds, again, you have got the two options: hemodynamically stable or unstable. Hemodynamically normal patient or asymptomatic, and there's a stab wound is there. You would like to locally explore the wound. If you see the fascia is intact and there is no facial penetration by a sharp object, then you will observe the patient for 24 hours or discharge as per the rules of your hospital when we are working. If your facial penetration is present, then you will go for the DPL. Turn out to be positive, go for laparotomy. If it's negative, go to the observation, right? But if you are tertiary care, you can also skip these options and go for the CT scan abdomen. In case of a hemodynamically unstable patient with frank peritonitis or evisceration, you will go straight forward for the laparotomy, right? Thank you. Now coming up to your questions, which we have discussed earlier. In question 1, 25 years old male, rider of a motorbike, had RTA with a car coming from one way, breaking the traffic rules, and had fall, striking the footpath corner. He's otherwise alert, but pain and agony, taking to ER. Vitally heart rate 110, which is high, abdominal examination, bruise and left hypochondrium, care sign is positive, fast is positive. How can you approach this patient? Okay, in this category, as per the, okay, so what are the answers we have? Ultrasound, Zanula has no okay. In Zanula, I think is a RTA patient. Go for the laparotomy. Okay. Ultrasound and then laparotomy. Resuscitation, look for the splenic rupture. Okay, Adhika, good answers. So as we know that the patient is hemodynamic is not stable. Heart rate is 110. Now this 110 could be because of a pain, right? Because he had a fall. Now, but he's maintaining blood pressure. That means perfusion is good. But remember, he has a bruise in left hypochondrium. That means something is fishy at the left hypochondrial region. And the occupant of a left hypochondrium is the spleen. So you have a positive care sign. That means there is a left shoulder tip pain because of the blood around the spleen irritating the left hemidiaphragm, which has got a dermatomal association. The tip of a diaphragm is 3035 level, and you have a positive care sign, and a FAST is positive. So this patient has got the splenic trauma. So you will, number one, will go for the guidelines, which tells you go for the primary survey, that is A, B, C, D, E. So your answer should be, for any trauma patient, has to be start with the A, B, C, D, E. That is maintaining the airway, breathing, maintaining the circulation. You have to put the 2 large bore cannulas, resuscitate the patient. You have to make sure there's no disability or fracture anywhere else, right? You have to control the environment, start resuscitation, right? And then you can go for the adjunct, because in this part adjunct has been done. So we will shift to the second part, which is the another part. The another part is that you go for the secondary survey, which you, and then adjunct to the secondary survey. Now you can go for a CT scan in this patient, as this patient is not that bad. He's not pale, he's bleeding, but he's not that bad. So you can go for the CT scan abdomen, and you will judge how bad the spleen injury is there, because grade 1 and 2 injuries of spleen can be managed conservatively by observation and blood transfusion. For grade 3 and onwards, you will definitely have to go for the laparotomy. So my answer would be resuscitation. Start with ABCDE, resuscitation, observe, adjuncts because it has been done, secondary survey, which is CT scanners, find out the grade, and then treat according to that, right? Case 2, 35 years old male, victim of street crime, an incident of mobile snatching, sustained stab wound by hooligan on Saturday night. He was taken to the emergency department immediately by the locals of the area. During the examination by the emergency department physician, he was found to have a small wound in the left iliac fossa. That is indicating the entry wound of a stab, in which you can see a bowel herniating out of that wound. This is known as evisceration. And remember, in a penetrating trauma, we have two options: that hemodynamic stable, unstable. With with evisceration, your answer would be laparotomy. Laparotomy, good. So yes, Zanula, you're right. For evisceration of an organ, you do not have to wait and watch for observation. This patient immediately required laparotomy because you can injure this bowel point, because it's very fragile organ. You don't want this to get puncture. If you get puncture, still this will be a big hell out of a problem. You would like to do laparotomy in this patient. The answer to this will be yes. Again, start with ABCDE. Okay, you might go for the adjuncts, but you don't require adjuncts this time because this patient has got the evisceration, and you go for the laparotomy. Right. Okay, sir. Okay, guys. Thank you. If you have any questions, you can ask.